Okay, I think we're live. Okay, great. Hello, everyone. My name is Randolph Lyde, and welcome to our afternoon session entitled Exploring Critical Race Theory and Medicine, Anti-Racist Patient Care. Again, I'm Randolph Lyde, a fourth-year medical student at the Lewis Katz School of Medicine, and I will be your moderator for this session. Originally defined by legal scholars in 1980, CRT has evolved over time and now creates a framework for individuals to examine the intersection of race and law, and so much more. It also allows healthcare professionals to confront and dismantle racial injustice and is pivotal in the continued goal for health equity. In recent history, critical race theory has come under fire nationally and is a hot button issue in America, and even going as far as having over 26 states introducing legislation to restrict teaching of CRT. Today, guests, we have Dr. Bram Wispelwey and Dr. Edith Mitchell. And we will be talking about their experiences with teaching critical race theory, how institutions can implement education on critical race theory, and also we'll be talking about anti-racist patient care as we move towards this standard. First, I'll introduce Dr. Wispelwey. Okay, so Dr. Wispelwey is a co-founder of Health for Palestine, a community organizing initiative in Palestine refugee camps that seeks to maximize wellness and address health barriers via social accompaniment and creative integration with existing facilities. He is an associate physician in the Division of Global Health Equity at Brigham and Women's, an instructor in medicine at Harvard Medical School, and he also teaches at the Harvard T.H. Chan School for Public Health. Bram's research, education, and implementation efforts focus on anti-racist strategies, address hospital admission inequities, community health worker impact, and settler colonial determinants of health. Before the start of his medical career, he pursued LGBTQ rights activism, which informs his health approach at the bedside and in advocacy. Bram is the senior technical lead with Partners in Health United States and a senior fellow at the Atlantic Fellows for Health Equity. Welcome, Dr. Bram. Thank you for being here. We also have Dr. Edith Mitchell. She'll be coming on soon. I think she's just trying to figure out the logistics, but she's a retired Brigadier General of the United States Air Force and an oncologist. She's a clinical professor of medicine and medical oncology at the Thomas Jefferson University. In 2015, she became the president of the National Medical Association. In 2018, Mitchell received Jefferson's Achievement Award in Medicine for her contributions to science and humanity. She later became the first Black woman to receive the PHL Life Sciences Ultimate Solution Award. Mitchell is editor-in-chief of the Journal of National Medical Association. Welcome to you both. And so, with this pivotal talk, and me myself not knowing fully CRT, and everyone having different perspectives, you have the right-wing perspective and the conflated perspective and the caricature perspective. Can you, Dr. Bram, give us an overview of CRT and kind of explain to everyone so that we all have a background and baseline knowledge going forward?
Absolutely. Thanks, Randolph. Thanks for having me on. I'd be happy to. And, it really is one of those things because it's taken on so many meanings, both by people who use it for, who really believe in it and believe this is a powerful theory to be utilized in work, and then also for people who are sort of anti-CRT. But it has very broad meanings on both sides. So I think you already talked a little bit about kind of where it came from. I'll just do that a little bit as well, just to give the context is really, really important to understanding what it is, why it's being used, and why also there's so much of this movement. So, as you mentioned, back to 1980, 40 plus years, a group of legal scholars predominantly got together, especially really after the civil rights movement, which at that point was maybe 15 years.
Dr. Bram, you're cutting out a little bit, just a little bit. Is it just to let you know?
Okay, sorry about that. Is this better?
Just a little bit, yes. Thank you.
Okay. So, we're about 15 years past the civil rights movement, And what legal scholars were noticing, legal practitioners, was that even though civil and criminal equality was achieved by Americans, there was still deep racism in the law and in the way the law was being handled, even in this more broad race. And so that's where the and from there we spread into the education realm and into many other areas, including health. And I'll talk about that really through the work of Chandra Ford and Collins Arienbua. Chandra Ford's out at UCLA in their public health critical race praxis. One definition that I think is particularly helpful in terms of now kind of after it's spread beyond the legal realm is from Kimberly Crenshaw, one of the really the founders of critical race theory. And she says it's a practice, right? CRT is a practice. It's a way of seeing how the fiction of race has been transformed into concrete racial inequities. Another group, two scholars who have written extensively, wrote a book on this, Delgado and Stefanchich, say that critical race theory movement is a collection of activists and scholars engaged in studying and transforming the relationship among race, racism, and power. So I think those kind of give that broad sense of what it is and what folks are trying to do with it. Unfortunately, it's become a catch-all, despite being really a graduate level series of scholarship, and that takes on really a number of different tenets, things from, the idea that racism is embedded in society, it's ordinary and pervasive, that race is socially constructed, and we can talk more about what that means, that different racial groups are differentially racialized based on historical factors, intersectionality, interest convergence. There's so many different components of critical race theory. And essentially what it's been sort of demonized at is sort of any real discussion about racism in society today, whether or not that is actually taking into the tenets of critical race theory or not. So that's kind of, I think, the broad background. Its utilization in public health and medicine is really only about 10, 12 years old. From those first papers published by Chandra Ford, but it's now really broadly being used in a lot of research, a lot of scholarship.
Thank you for that background. Can you talk about your experience with critical race theory? What got you involved and kind of why you wanted to take this path that you're going down?
Great. Yeah, it basically comes down to documenting an example of institutional racism in our hospital and thinking about how we wanted to engage it and how we wanted to transform the racism that we found institutionally. And so essentially, when I was an intern, we were noticing we have two buildings in our hospital, Brigham and Women's Hospital, where patients with heart failure could end up. One is the general medicine building, shared rooms, smaller spaces. You don't have, you're seeing hospitalists like me. The other one is in the cardiology building. You're seeing cardiology specialists. You have specialty trained nursing, more natural light, big family rooms, totally different patient experience. Only about 60% of patients would go to the cardiology ward. About 40% would go to the medicine ward. What we're noticing is that it wasn't happening randomly, right? Patients of color seemed more often to be going to general medicine, and white patients would end up on cardiology. We looked into the data, and this is where the critical race theory came in. We're noticing this problem, anecdotally. How do we research this in the right way? How do we make it clear that what we're researching is racism, not race as a biological construct? So that's where the public health critical race praxis, which is, Chandra Ford's pulling of critical race theory into public health research and medical research, that's where we use that framework in our paper, which we published in 2019. And the final component of public health critical race praxis is action. So then we were also, from the beginning, when we started the research, we were thinking right away, no matter what if we find an example of institutional racism, we're going to develop an intervention based on these findings. That's important because we can't just be another group that's documenting racism. Like the number of documentations of racism in the hospital are extremely extensive. They filled many reports, but we wanted to make sure we were going to do something about it and do something that really felt meaningful and that felt like there was institutional accountability attached to it.
I love this idea of action, and I want to get back to that in a little bit, but I want to talk about your journey a little bit further. as medical trainees, especially ones who are largely people of color, when we bring up issues of race and race, conversations, they're not always met with, of course, a warm hug. I'd love to hear your experience kind of, bringing this forth to the Brigham, and then also if there was any backlash or any conversation around your paper when it was written, and then what did that look like?
Yeah, great question. So the external backlash, before that happened, right? Before this became, a local story and even to some degree a national story in white supremacist circles, there was a lot of internal struggle, right? So a couple of the lead folks working on this, we have backgrounds in organizing and activism. You read a little about my bio, done a lot of LGBT rights activism in the past. Michelle Morse, who's now the first ever chief medical officer of New York City Public Health, is an incredible organizer, and she really directed a lot of the internal organizing around this issue. So we found this example of institutional racism. Then we had to start telling people about it in the hospital, and there was a lot of pushback, right? And this is pushback is a predominantly white institution, and what most people really identify as progressive and liberal and even anti-racist, but it's the kind of thing where it's like, well, we know it's pervasive, we know it's everywhere, but it's not here, right? When you shine the light, and makes people really uncomfortable. One of the most uncomfortable things for white physicians, and this has been documented, is the idea of being seen as racist. That's one of the most anxiety producing things. This has been shown in studies. And we really saw that firsthand. People responded really defensively. We ended up doing things that were pretty much unprecedented. We gave the data to other statisticians that people wanted to look at it. But eventually, slowly, through discussions of the tenets of critical race theory and the idea that this was structural and institutional, we weren't really talking about interpersonal. Obviously, that comes into it, right? The biases themselves. But we were saying, hey, this is an institutional problem. We're all complicit. We all need to make this right. And slowly doing that internal education and having all of those conversations, we started building a movement of folks who were on board with this. And that was key, because then what happened, we wrote a paper about it. In part, that was strategic too, right? Because we were like, we want to do something a little more radical as our intervention. So we're going to kind of go and put it out there and see what people think. But, when the backlash started, and I can talk about what happened there, we were then prepared, and we had the chair of medicine was on board, the chair of emergency medicine was on board. We had done a lot of that internal organizing to ensure that, when threats of violence started, which they did, that the hospital really stood behind this ultimately, and they did. And we've started the pilot project that we had talked about. But essentially, like, what happened was, when we said, hey, we're using critical race theory both to understand, this institutional racism, but also to come up with an intervention, right? And our intervention was based on really, a framework that we borrowed from theoreticians and scholars of reparations. So Sandy Darity and Kirsten Mullen, who wrote a book called From Here to Equality, on the rationale and justification for federal reparations for descendants of enslaved people. And their core insight and their core mechanism that the federal government needs to take is one of what's called ARC for the acronym: acknowledgement, redress, and closure. There needs to be an accountability. The impacted communities need to be involved in the process, right? You need to own it. You need to acknowledge it and take responsibility. You need to provide compensation, right? The redress component. And then finally, you need to get to a place of closure. You have to involve impacted community to say, hey, we've done this process. Is this right? How can we make this better? And we're saying, hey, that could be a great model for institutional accountability. Because if we find these examples of racism, like, these are patient safety emergency for patients of color. We have to take this seriously. And that means there needs to be a mechanism to hold institutions accountable. So that was the model we put forward. And when we did, it started with attacks on Twitter, on social media. White supremacists were attacking Michelle Morse, a Black woman, a leader in New York City, and really started attacking her Twitter, and we were like, wow, this is like kind of blowing up. And then some right-wing publications started writing it. Then Fox News picked it up. Then it was on Tucker Carlson. And then it became a big issue. We started getting tons of hate mail, threats were called into the hospitalist office, threats of shooting up the emergency department. The social media handles of the hospital were all attacked. This was all about 1 year ago, last spring, and was very intense. But ultimately, because of all that internal organizing that came out of the fact that this was so hard, I think, for everyone to accept, really in the hospital, that we were ready and that we were able to push forward.
Thank you for that. And I'm sure that must have been such a scary time. And I want to talk about that as well. Just so everyone also knows, if any student has any question or any attendee has any question at any time, feel free to put that into the chat and we'll address it. But as we're moving forward, we're just going to continue the conversation. But feel free to ask any question that you guys feel like you want to ask. I want to talk about number one, especially for students who bring up these issues or individuals who bring up these issues, you talked about like kind of shining that light and, getting people to see and understand what's going on. How did you overcome the hurdle of this isn't me? And you kind of talked about, de-identifying and de-individualizing it and saying this is an institutional issue. But I'm sure there was still some sort of like some individual saying like, you know what, this is not our problem. This is an other problem at some other institution. How did you kind of confront that and break through those barriers?
Yeah, that's such a good question. And your point about thinking about for students, I think too, one thing I neglected to mention that I just want to mention is that the only people who could have noticed this were actually trainees, right? Which, many of you are probably very close to being, so we were interns, and because all the attendings were only on one service or the other, they weren't on both services, but as interns, we worked on both services. So we're like, hey, this is not operating the same. So there are things that you will notice, both because you're, perceptive, right? And people of color, of course, are seeing these things much more readily. And, that I think that like the education level of this generation is very different on these issues. So you'll notice them. But even if you think they're obvious, right? Like people for reasons of white supremacy, right? These won't be seen and they won't be acknowledged. And so that, I think gets to that part of the question, right? Which is when the denialism started, how, or, the defensiveness, how do you kind of break through that? And I think, what we did is we started every meeting on this topic, and we eventually, it was medicine residents who started looking into this, but then we brought in the emergency medicine team and the cardiology team because it affected all of us, because we were talking about heart failure patients. What we did was we started every meeting with a discussion of basic definitions. So we would say,
sorry, I think I'm on.
No problem. Hi, Dr. Edith.
Hello.
Hi. We're just going through one question with Dr. Bram, and then I'll formally reintroduce you, okay? How does that sound?
Okay. I need to get to, okay, there's my presentation.
Awesome.
I'll need to pull my presentation up.
That sounds great.
Okay.
All right. Go ahead, Dr. Bram.
So we would start every meeting with just going over really basic definitions, like what, even race, racism, like, we used a lot of Kamara Jones's work to really explicate these for people, and really then breaking it down into, interpersonal, institutional, structural, and really then talking about how we were framing this example of institutional racism. So what we did was say, hey, here's what the data shows. Here's how we understand it based on, really a lot of critical race theory, although we weren't initially necessarily using the term, but utilizing that to then explain it, just to kind of try to get everyone on the same page. And then over time, people, in this group meeting, without calling anyone out, but sort of giving them a chance to sort of be like, oh, when they're talking about racism, like this is what they mean, and this is how it's approaching. So a lot of it was actually just like co-education and discussion as a way of diffusing the tension and sort of saying, this is the problem, this is how we're going to go forward with it, in a way that was really kind of calling people in, as opposed to like, trying to minimize the pointing of fingers, which was a lot of the initial, impulse when this started.
Thank you for that. And I want to, at some point, circle back, but I want to give Dr. Mitchell a chance to introduce herself. So we read your bio, Dr. Mitchell, but currently we're talking about Dr. Bram's experience with critical race theory and shining a light on, when say, what, this isn't a me problem, this is someone else's problem, and then how to address that. But I would love to get your perspective, and you can also start your presentation of, how colleagues on board.
Sure. So this is a long-going problem. And I think for each unique situation, you have to figure out how to handle it, what to say, because each is different. So I'd like to talk about my own experience. I graduated from medical school in 1974. And where I went, the Medical College of Virginia had a 3-year program and a 4-year program. So I wanted to get out of medical school. I was not a typical student. I had taught high school for 2 years before going to medical school. So I thought I'll finish this really early. And there was a form that you had to have your advisor sign. I had never met my advisor before, so I was going there, get him signed this form, and I take it back to the dean's office, right? And he said to me, well, I can't sign this. And I went, why not? The instructions to all the students was to get your advice. He says, you people don't do good at this school, and I have signed you up for a tutor. And I went, what? I've never needed a tutor before, and I have a 3.83 undergraduate record, and I was in the 90-something percentile on the entrance exams. Why do I need a tutor? So I almost gave him a few words. And then I thought that isn't the right thing to do. So I said, thank you, and left, went back and told the dean. And I told him I was bothered by assumptions that all Black students need help. And maybe I won't do well in this school, but my credentials are as good as anybody else who entered. So he said, okay, understand, you don't have to go back. I'll be your advisor. Great. So I did graduate in 3 years. And my thing was to be better than the next person and make sure that their assumptions are not supported by my work. And another event, we're getting white coats. And I go to the place where you're supposed to get, white coats fitted. And the lady said to me, honey, you think you're going to like working in the kitchen? Now, I am an expert cook. And I told her, I said, well, I work in my own kitchen, but I'm here to get a white coat for a medical student. And there was, and silence. So I think that you cannot allow those instances and incidents to pass without some reaction. But I think you have to stop and think a moment and think about what will be to your advantage and the advantage of other students, because those things have not happened just to one person. They happen to others. And one of the things that we have to do is encourage system change. It's not just equity, but it's justice. And you've got to think about what will make the positive experience. And to be honest with you, I think about Dr. Martin Luther King. And I think about, what would Dr. King say in this situation? We know Dr. King would speak, but I ask myself, what is going to advance our efforts? And you can do things that can negatively affect them. You can do things that positively affect them. I don't think there is any one way that anybody could tell you that's going to work for every person in every situation. There's no way to do that. But I say, just step back, take a deep breath, and the words will come. But think about whatever you say is not only affecting you, but it's affecting all Black and other racial minority students. For me now, faculty. And what I try to do is make sure that the picture that I portray is one of excellence, is one of positivity. And even now you think that, well, what do you have to prove now? It never goes away. There are incidences for faculty members, for other situations. And what I try to do is just be better than everybody else. And in my own department at Jefferson, I try to make sure that I've got the things. And I was recently inducted into the Royal College of Physicians. And to get there, you have to be in the American College of Physicians, which gives you a listing of FACP behind your name. But what I did, I applied for mastership in the American College of Physicians. There are 3 people in my department who can put MACP and not, I've passed FACP. And you have to be MACP in order to be considered by the Royal College of Physicians of London. So I am I'm numero uno in my department in the Royal College of Physicians. And I'm not saying that to, boast what I've done, but again, is focusing on being the best, being excellent, so that there are fewer criticisms. And then when somebody says something that's inappropriate, step back and think. Another incident happened just a few years ago when they were talking about the new fellows coming to our department. They were all white. So I asked, why don't we have some diversity in our group of new fellows? And somebody said, well, we could not take anybody who was inferior. Now, that's the one time I did jump up. Now, we're all sitting around a table, right? I stood up and I almost said, what the H, but I held my breath. And I said, well, do you think I am inferior and that people are inferior because of their color? That's inappropriate. But what we have not done is considered appropriate applicants to the program. And we need to increase the diversity of our fellows, our students, our patients, and making sure that we're encouraging. I said, you can't say that people are inferior just because of their color. And then, of course, recognizing that I'm MACP and they're not. And I said, you think I'm inferior because of my color? But I couldn't let that pass. And again, I think about what would Dr. King say? He would say something about the fact that his little children, will have the opportunity. Remember that speech? And he says, I hope my little children will not be heard by the color of their skin, but by their tongue. And I think that for all of us, we need to work collaboratively, look collaboratively, call others when you need to blow off some steam. And we all need to do that sometimes, but you cannot let people get by. And I think it's up to us who are in academic medicine now to speak to those occasions, to speak positively and in a way that's going to allow for change. And we've got to work with our health systems to make sure that we've got equity there. And it's equity for us who are there now. It's equity for those who are coming along behind us.
I couldn't agree more. And thank you so much. And, really hearing your accomplishments, your prolific career, everything that you've been through, it's such an inspiration. So thank you for telling us this. I want to circle back and listening to and kind of what you were talking about. One word that comes to mind is, well, maybe fearless or perseverance in the face of fear. And so with you, Dr. Wispelwey, when you talk about, having people from Twitter wanting to come and shoot up, the hospital, and you, Dr. Mitchell, having, your advisor telling you that you weren't a student that would do well, and you persevering through those times and, going through those, experiences. Can you both talk about how, and for you specifically, Dr. Wispelwey, how did you overcome, that, I would imagine fear of would something happen, or, what potentially could happen?
Yeah, it was, the nice thing was, at least, for each of us, is that there were two of us kind of under fire there. So, Michelle and I were able to kind of like share what was going on. Whenever we would get messages, we would tell each other. But there was also a larger network of people who had been through this before, and it mostly Black women. So Aletha Maybank at the AMA had gone through these processes. So she really told me, here's what you should do. Here are steps you can take for your safety. And so, one of the things that came out of it was sort of like thinking about building this community and building a playbook for people when they get attacked in this way, that they can protect themselves, that they can feel like they have a community behind them. Because, the larger goal of these kind of attacks, in addition to intimidating the people themselves who are the targets, is to create this chilling effect so that people don't engage in this work, right? It's that, the personal cost starts to feel too high and sort of scaring people away. So I think, one of the things we're strategizing on now is how to, support each other and have this kind of like rapid action plan to make people, to get people feeling safe, to get people supported, such that, because this is going to keep happening, like this, we're in this wave. Eddie Glade at Princeton, was just talking last week about, every time there's, we make the progress, that Black folks make progress in this country, there's this backlash, right? And, we had the largest social movement in the last 50 years, right? People on the streets in 2020, tens of millions of people out. And now we're seeing a level of backlash, this dialectic that is very extreme, right? And it might get worse. So I think, like, figuring out how we're going to support people doing this work so we can keep pushing forward and not have to take a step back in this work. So yeah, so I think that's what we're still working on, but it's it's a challenge.
Oh, absolutely. And Dr. Wispelwey, I would invite all of you to join and be active in the National Medical Association where there is experience in these opportunities to advance medicine. Also, you learn about others. And I follow the quotes of James Baldwin. And James Baldwin said, if you should look behind you, and if one can identify those aspects that have been important, if you know from whence you came, there is no limit to where you can go. And I think we all, if we understand the past. So let me tell you a bit that happened last week. How many have heard of Dr. W. Montague Cobb? Dr. Cobb was an anthropologist and on the faculty at Howard University. He was very, very big on social aspects of medicine. He was chair of the board for the NAACP while being a medical school professor. He also served as an advisor to former President Roosevelt and to former President Truman, and was very close with President Johnson. He was a participant in the writing of the Medicare bill. And when the Medicare bill was approved by Congress, former President Johnson flew to Kansas City and signed the bill in the Truman Library, since former President Truman was the first to request from Congress funding of a bill for healthcare for the elderly. And guess who went on the Air Force One with him? It was Dr. Cobb. Dr. Cobb is credited with more than 1,100 literature inclusions. So he was a prolific writer. I am told by Howard graduates that he was a prolific teacher, very close. So last week, they renamed the street in front of Howard University School of Medicine, W. Montague Cobb Way. And again, it's looking back at the past through your rearview mirror and being able to understand where you want to go. And I think for all of us to come together in collaboration, work with the National Medical Association, so we have a choir and united voice. I'm inviting you to come. I'm inviting you to write. I am the editor-in-chief. Oh, and Dr. Cobb was the editor-in-chief of the Journal of the National Medical Association. I am now the editor, and I encourage you to submit manuscripts so that others can see your work, your productivity, and therefore we've got a larger choir singing the same song as you, same song as me, but others who are actually older than me who have experienced various incidents and so forth. And I think we can together collaboratively address the Congress for more funding for healthcare, whether it's healthcare research or healthcare delivery in our communities. So I encourage you. And the meeting of the National Medical Association will be at the end of July. Let's all join forces. Let's submit those abstracts for presentation. let's make our voice be heard by more than our audience today.
I couldn't agree more. And having that audience and making sure that people hear our stories. And Dr. Wispelwey put in a story into the chat showing the backlash that his colleagues have experienced, and shining those lights on those voices as well is super important. So doing that is paramount. I want to take us back to critical race theory and education. In the beginning of our talk, I talked about how there's been new legislation in many states to restrict the conversation around, race, ethnicity, and the education of those tenants. And so, how do you both go to your institutions to have them talk about these things? How do you start that conversation? And do you feel that, at your institutions, those conversations are met with open arms, or are they met with closed doors? And how do you open those doors?
So again, I like to talk about action as opposed to just conversation. So I am a member of the College of Philadelphia Physicians. It was the first medical society organized in this country, numero uno, 1787. And there are not a lot of members who look like you and me. I started with nominating some more Black doctors. And in order to do that, you have to have letters. So I wrote emails to some of the higher ranking physicians in Philadelphia. So I nominated one of the doctors from Temple. And what did I do? I wrote to the chairman of her department at Temple and say, hey, don't you think it's high time that we nominate XXX to join the College of Physicians? I am writing a letter. Will you write one? And he immediately said yes. And I wanted to tell him, you should have nominated her in your department years ago, but I wouldn't stick that knife out there. Now I've got a lot of people on board at the college to support my efforts. Also, many of you don't realize that none of our medical schools years ago would allow Black doctors on the practice staff. So that Dr. Wright, who was surgeon, went to Harvard. I'm told he was fourth in his class at Harvard. And he was told by Dr. Cushing that he could not get a residency in Boston because they didn't allow Blacks to operate on white women. So Dr. Wright went to Howard, got trained in surgery, and therefore was really supportive of medicine. He was also chair of the board of the NAACP, and he convinced President Roosevelt to stop building those Black hospitals like Tuskegee and others. And he paved the way for us. So what I did in Philadelphia, there was a Black hospital named Mercy Douglas that was organized by the first Black graduate of the University of Pennsylvania School of Medicine, and another doctor who graduated from Jefferson, where I am. And they later merged. So one built Mercy Hospital, the other built Douglas Hospital. They merged into Mercy Douglas. And Mercy Douglas, for a long time, was the only place in Philadelphia that Blacks could obtain postgraduate medical training. And they later established a nursing school. So what did I do? The NMA had a small event, Mercy Douglas lectureship. And I thought that was important. So when I came to Jefferson, rather than tell Jefferson how segregated they were, I said, why don't we assume this Mercy Douglas lectureship and support it and promote it? They didn't tell me no, but didn't really embrace it. So then I got the College of Philadelphia Physicians involved, and it was supported by all and recognizing the contributions of Mercy Douglas Hospital. And I told them this was not only for Black health care in Philadelphia, this was for all healthcare. And I enumerated some of the nice things that happened about Mercy Douglas Hospital. Now they all embrace it. Temple, Penn, Jefferson, all of the medical schools. So sometimes you have to have action. And action speaks louder than words. So therefore, we need the conversation. We need to address racism in the healthcare setting. But we also need to step out front and find some things that speak louder than words. So just last week, I get a letter from the university president saying, you are being given this award because of your volunteerism in activities. So I think collaboratively, if we all get together, we can do this.
I agree.
So I invite you to the meeting of the National Medical Association, and let's form a group, not just our individual institutions. So, Dr. Wispelwey, I would love to have your manuscript.
I couldn't agree more with what you said, Dr. Mitchell. I think that collaborative strategic organizing, like you said, and then I went to this group and got them on board, and that snowballing is the same process we went through ultimately to make change. Standpoint, Randolph, what we started with was, who are natural allies in this movement, right? It was students, it was residents. So like I would spend a lot of time talking to them, right? Talking about critical race theory, talking about our work, still do a lot of that. And then, working together to think about like, all right, like we have to talk to the chair of the department, right? He
Absolutely
on board with this. If he's not, it's not going to go anywhere. And so, who needs to be in that meeting? How are we going to approach it? Let's get the slide deck right. What is he really concerned about? So it's like, there's a lot of strategy, but ultimately it leads to exactly what Dr. Mitchell, was just saying, right? It's that you get more people on board, and then suddenly you have enough strength, even if it just started, as a few individuals, you now have that collaborative strength to kind of push forward and maybe do something, or get something passed that hasn't been done before. And I think, it's also, that's how we, protect ourselves too, as someone who's like very junior faculty, right? You are students, right? You're thinking about residency, you're thinking about next steps, you have to do these things as a group, right? Because with these power structures, sometimes, you don't want to be, in a position where you're getting singled out.
Yes, I agree.
Or I consumed by the system. You don't want the system. You want to keep your motivation and your activities ongoing so that there's positive benefit, but you don't want to get consumed by the system. And they won't tell you for what.
Yeah.
You know, you're just whisked away.
Yeah, that very passive aggressive. Yeah, that's true. Like that's true. You will maybe won't find out. You won't necessarily get the straight answer. That definitely happens.
So a couple
I've
of
been
things
in
I
a lot
wanted
of situations. I've had a lot of experience since graduating from medical school in 1974.
Mhm.
And I've seen a lot. And I never say I survived it all, but at least I'm still kicking.
Yeah, definitely still kicking.
I've made some positive marks. And I reach back for the students. I'll be with the Student National Medical Association next week. So, it's really, we'll have more strength in working together.
I agree. One thing that you mentioned, Dr. Mitchell, is action. And one of the tenets of CRT is action. And so, Dr. Wispelwey, this question is directed to you. What are some action steps that trainees can take, seeing as you've kind of taken them as a resident and as a fellow, that you can get involved and kind of start this mission?
Yeah, I think there's two. And, one of them, Dr. Mitchell, you already mentioned. I'd say the first one is, that act of noticing, right? You might, think that, hey, no one else is seeing this. But if you ask around, like maybe people are, right? So first kind of like make sure you notice, because that's how this all started. Like we're 6 years in now. It was really just kind of being like, are you seeing this too? Like, this is racist, like what's happening here in the hospital, right? So that was number one. Number two is what was key in this work was getting the data and having that leverage, because that's the thing in science and academic medicine, right? They can't argue with that. We gave it to multiple statisticians. They tried and they couldn't, right? It spoke for itself, and that was powerful. So, as Dr. Mitchell was just mentioning, get those abstracts together, get a group together to do a research study and make that happen, because that will give you a lot of power and ability then to get to the action step truthfully. And frankly, even with the way we're doing the intervention, there's even been legal challenges, right? And there's going to be more. The data has been essential to doing that. It's sad because, like, we know this is the case, right? Like, we know this is the US, we know there's racism in care, but we still have to have that data to show it, because otherwise, it's going to get knocked down.
Makes sense. Definitely. And with large institutions like the Brigham and, academic medicine, the data is all. We have a question in the chat. So the question is, Dr. Wispelwey, how did Brigham respond to the CRT backlash that you experienced with Dr. Morris?
So initially, there's not a lot of support. There's even one Fox News segment where they kind of make it sound like they're like, oh, Dr. Morris and Dr. Wispelwey, their views don't really necessarily reflect ours. So there was a little bit of distancing initially last spring. And I think because they were scared, because they, like I said, their social media handles were getting attacked. They were getting threats of violence. It was interrupting patient care to some extent, actually. And, it was a little bit of that, unsure of how to respond to this initial backlash. Then we had some big meetings all the way at the highest levels of the hospital later to kind of talk about how that felt and what our experience was. And Dr. Morse in particular, as a Black woman at Brigham for many years, like what it felt like. And so some changes were made. And then when a group of neo-Nazis came to the hospital in January of this year, and they were passing out flyers with Dr. Morse's and my photo on them, and spreading a number of lies about the work. There was a better response this time. New president, new leadership, and there was a stronger response based on the feedback and based on kind of the prior experience. So I think there had been some progress over time, but I think one of the things we realized, and I think now we're trying to broaden it to multiple institutions, is saying, hey, what is the appropriate way to respond when this happens? How can we support faculty and students and trainees in these kind of situations. So that's one of the things we're hoping to work on. But yeah, it was tough. Like, we felt very alone last spring when it started.
I can't imagine how that must have felt, especially with having different groups come to the hospital and come to the area. I would personally be afraid of my safety, and so thank you for continuing to do that work. My next question really centers on the conversation of race. And so a lot of people, especially in healthcare and in the nation, will say that talking about race and having these conversations around race just further divides us, and it pulls us apart. And Dr. Mitchell, you mentioned earlier that we have to come together and we have to, bring people together to move these issues forward. What would you how would you instruct trainees to have this conversation to either a physician or a fellow colleague when they say, you know what, talking about race and these race issues just doesn't move the needle?
So I actually talk about James Baldwin's theory that know from whence you came, and if you know from whence you came, there is no place you can't go. And we didn't bring racism here. We didn't bring racism in medicine. When they brought the slaves, even before the country was founded and there was a Declaration of Independence, slaves were here. The slaves came to this country sick, and here we are over 400 years later, talking about how racism has affected medicine. It's real, and you have to let people know it's real. I don't know, Dr. Wispelwey, if you have worked with the Accreditation Council for Graduate Medical Education, ACGME. You didn't ask me for recommendations, but I can tell you that ACGME is looking at this. Did you know that more Black residents leave their positions before graduation in this country? There are data, and you don't have to struggle to collect it. ACGME has it, and ACGME is addressing it. The number of practicing clinicians in this country, practicing doctor clinicians, hasn't changed for several decades. It's been 5% or lower. Therefore, somebody's got to do something about it. But if you have residents getting kicked out of I shouldn't say kicked out, leaving their program before graduation, that's real. And most of the individuals probably didn't elect to leave. So you're not going to get a group big enough to affect change until we break that 5% ceiling and have more practicing clinicians, physicians in this country. You've got your degree, so what can you do to help medical students get through? Help residents get through their program. So work with the support systems that you have. And ACGME is a big proponent of this and are investigating it and have written about it. So look at some of the work presented at ACGME. Again, it's the collaboration and all of us working together. And I find ACGME is a big proponent of all of the things that we've discussed today.
Thank you for that.
Inappropriate conversation, inappropriate mannerisms, and ineffective promotions within schools. You know, what does it take to become an assistant professor? And what does it take to become an associate professor? How many full professors are there in departments? So it's recognition for your contributions. And a lack of recognition is basically racism. So again, collaboration. So collaborations with all of the entities that can provide input. You don't have to have a war of just your own. There are others that will supply the tools for you. There are others that will supply ammunition that you use. You know, and I'm not talking about just fighting a war, although I did get promoted in the military to a nice position. I was the first woman doctor to reach that level. But we've all got to be strategic planners rather than just making noise. We got to do something.
Couldn't agree more. I wanted to shift the conversation to allyship. And Dr. Bram, can you talk about being an ally and being able to pull in other allies in the face of these times and adversity, when, you know, a lot of people are saying we shouldn't talk about critical race theory, we shouldn't be looking at anti-racism efforts? How, as an ally, do you pull in other allies, and how should we as students and trainees go about doing that?
Such a good question. I think, you know, I think about allyship a lot, you know, as a white doctor doing work, you know, on anti-racism in the hospital. And, you know, one differentiation I read recently that I thought was really helpful is that, you know, sort of distinguishing even like sort of maybe allyship versus more accomplice, or what Daruba bin Wahad calls co-conspirator. Like, you know, I heard a talk from him once where someone was like, oh, you know, what can we do as allies? He's like, we don't allies. He's like, we don't need any allies. He's like, what we need are co-conspirators. Like, we're in this together. Like, we're doing this work together. So I think, you know, a lot of times, you know, what I think is important is that a lot of allyship can end up being really like performative. And I think what's important, and what I try to talk to other, you know, white physicians who want to do this work, is that, you know, to really be an accomplice in this work, you know, you really need to exploit, you know, a lack of visibility, right? This isn't about performing or like anti-racism, and like how do we do that? But so I think, you know, there has to be some of that, you know, organizing, you know, among white physicians themselves to really do that work. And I think that doesn't happen enough, and it's not strategic enough too, right? When we're talking about these complicated issues in the hospital, right? You know, we have different roles to play. There's different areas for us to step in and step back. And so, like, I think it's sort of an under-discussed and under, you know, approached issue overall, but one that's really important, and that I think even a lot of white folks who are, you know, maybe doing work, they aren't doing that side of the work. They aren't organizing. It's really trying to get, you know, white people involved. It's more like maybe getting this grant or doing that piece of it. But so I think there's a lot of work to be done there.
I 100% agree. I remember I had a conversation with a medical student or a medical applicant, and she was getting her MPH, and she likened it to, she was the person behind the scenes, but she was trying to push things forward so that the appropriate people of color who have the stories, to take the front stage to tell their experience, and that she would be the co-conspirator, as you put it, in the background. So having more of that is truly paramount. We do have a question in the chat from Mary Duggan. She said students often feel intimidated in doing the work as the people with the least power in the clinical setting. What advice do you have for students about building coalitions and demanding change in the workplace while taking personal safety into account?
So, if it's okay with you, I'll start.
Yeah,
First of all, you've got to have the allyship. So, the whole university, the whole medical school, the whole medical staff is not against you. So, get to know someone, get to know them well, and feel comforted, someone you can feel comfortable with. It could be a mentor, but it doesn't have to be a mentor who is just focused on your activity to achieve the medical school curriculum or the residency process and curriculum. Find somebody who you just like to talk with, who can meet with you periodically to discuss issues. And you will find that beneficial. You will find that there is somebody working with you, and somebody who can, in some cases, forge ahead for you, ahead of you. In other words, it's an ally. So that's what I found helpful over the years. And it has benefited me to have somebody who I can rely on, who I trust, who I can have a conversation with.
Thank you for that. Dr. Wispelwey?
Yeah, I mean, I think with students, I think again, similar to what Dr. Mitchell was saying and what we talked about before, like I think being part of a group and you're representing kind of the group, and I think that's where a lot of the protection is, right? It's not saying you're not putting yourself on the line saying we need to change this, being like, hey, there's a group of students who are concerned, this is our feeling, and really it's that we movement. And I think actually in a way students often do have a lot of power, right? There is the need, the university does have the motivation to make sure students are happy, right? Because even if it's purely selfish, right? Even if it's just about hitting their marks for their next year and making sure they get all the applications, they can't have a bad reputation, right? So I always think very strategically about those things too, with our work in the hospital, like the data. And I think as students, right, there is, if you can get a group together and say like, this is really important to us, like, they have to, school needs to listen. And I think if you do it in the right way, you can do it in a way that again, it's not falling on the individual. And I've seen students do that before, with a lot of the work, in White Coats for Black Lives, at our institution and elsewhere, where they were very bold, very strongly pushing for change as a group, and they did in a way where I think they were all felt really protected and able to kind of push that forward. It's not easy, but I think it can be done.
Thank you for that. In our last couple of minutes, I did want to throw out this question because it's part of the title of this talk. I would love to hear from both of you, what does anti-racist patient care look like? And what are some ways that as students, as trainees going into residency, and as faculty, that we can foster that?
I'm happy to start, and then I'll let you finish, Dr. Mitchell. I think a big part of it, because I think this is kind of low-hanging fruit, and it's something we're all involved in. So it doesn't, not everyone's going to be, starting a research project that's sort of involved in racism or anti-racism, right? You're going to be, you might be interested in doing, oncologic research or whatever piece. But the one thing that affects everyone, and it's built into the education system, is racial essentialism, right? So one of the big problems that I'm sure all of you have run into in your education is this, I think it's one of the biggest mistakes racist mistakes that's still ingrained in academic medicine, which is the belief that socially constructed racial categories, fabricated racial categories reflect inherent biological differences. We see this in the test questions that get written. We see this in the way we teach about blood pressure. It's still, all the things with the, EGFR calculation, kidneys. There's so many elements of racial essentialism that are still built in. So I think, one way to be sort of anti-racist in, throughout kind of the education period and beyond, right, even faculty, is to work behind the scenes too, to at least make change, to point out when those things happen. Anytime, race is being used in to falsely reflect ancestry or biology, that needs to be called out, because that, there's evidence that does a real disservice. It's not just in terms of contributing to interpersonal racial biases, which we saw on display in that study from the University of Virginia, right, about how the medical students, really have a lot of racist beliefs about Black patients, but also these systemic racial biases that create, these spurious standards of care, right? That we, there's lung function, kidney function, race corrections. There's different scores for VBAC, all of these kind of aspects, things that delay care for Black patients, right? For getting renal transplants. This has a real effect on patients today. And this is just the clinical algorithms and the clinical approaches we're using and the education that's happening. And like, at least if it, if your experience is like mine, like I heard a lot of, really racist sort of things just in the, in the scientific part of the education process. So I think that's something that we need to work on, because I think the effects of it are even bigger than just the clinical piece.
Dr. Mitchell. Thank you, Dr. Wispelwey.
Thank you. So I think that everything happens with collaboration. One person isn't going to affect change, but change can occur with groups moving in the same direction and all participating. So that what I think is important is to recognize the needs, identify the needs, and then we can strategically plan to address those topics, those needs, especially for the patients. And I encourage clinical trials. I have students, residents working with me on clinical trials and getting input from everyone. I love the input from the students and the residents, and I say young minds, young activities, that's good. But changes in medicine have happened through clinical trials. And historically, Blacks and other marginalized communities have been left out of clinical trials. They've not been included. You mentioned renal transplants and others. Blacks have been left out of those clinical trials. For cancer work provided to the FDA for review, less than 2% of patients on those clinical trials were either Black or Latinx or Hispanic. So that we've got to bring these communities into the clinical trials so that the outcomes of those trials, whether approved by the FDA or not, are apparent, that the patient populations are apparent, and therefore it's very critical that Blacks and other racial and ethnic minorities participate in clinical trials. So it's how do you gain the trust of the individuals that they can join the clinical trials? how do you get the education and information to them that there is a need for them to participate in clinical trials? So I think an area where there's much need in medicine is participation in clinical trials. It's also been shown that patients who participate in clinical trials have better overall healthcare delivery. So therefore, it's to the patients and the caretakers consideration and advantage for them to participate in clinical trials. We also know that there are biases that allow for non-participation. In other words, in a patient-reported study, when asked about participation in clinical trials, most of the participants in that survey said they wanted to participate in clinical trials, but they were never asked to do so. So we're not inviting, that's what the patients say. And patient-reported data should be listened to and should be emphasized so that we've got to include patients in clinical trials. And students and residents can be a tremendous asset to the clinical trials process. Might allow you to also write papers or abstracts or give presentations on your experiences, so that, again, the collaboration, how do you work with individuals who are sponsoring those clinical trials, who are writing those clinical trials, and who are responsible for the research team, inviting participation so that there is equity in participation in clinical trials. That's an important part of healthcare delivery. So my suggestion and final comment is to collaborate for the providers, for the patients and their caretakers, and for the community, so that we are moving forward with equity in healthcare delivery in this country. So I thank you for the opportunity to participate, and look forward to more collaborative endeavors such as this today. And I hope it's been beneficial to our audience. Thank you.
Yes, thank you so much, and really a pleasure to be on with you, Dr. Mitchell.
Same with you, Dr. Wispelwey, and I will be looking for that manuscript to the Journal of the National Medical Association.
Okay, perfect. We'll get working on it.
Okay.
Thank you.
Take care. My pleasure to be here with you.